cardiovascular pathology, congenital heart diseases. So for congenital heart diseases, we have to understand that there's two types of shunts that occur in the heart. First is the right to left shunt, okay? And that means that if there is a right to left shunt present once we're born, we're gonna have deoxygenated blood going into the left side of the heart, bypassing the lungs, and we're gonna get cyanosis immediately because there's deoxygenated blood going into the systemic circulation, okay? And so you will see cyanosis immediately, early cyanosis. Whereas, on the other hand, we can also have left to right shunts. Left to right shunts, you're gonna have oxygenated blood going back from the left heart to the right side of the heart and then going into the pulmonary circulation, which doesn't matter as much because we have oxygenated blood just getting reoxygenated. However, over time, that shunt will switch over and turn into a right to left shunt, which will cause cyanosis. But this will be cyanotic later in life, at around the age of 10. So left to right shunts will have late cyanosis at the age of 10. Right to left shunts will have an early cyanosis immediately. Okay, so beginning, we're gonna start with our right to left shunts. So immediate cyanosis. The first one we need to know is persistent truncus arteriosus. All this is that we have a failure to divide our truncus arteriosus into our pulmonic trunk and our aorta. So we don't have two separate systems, one going to the heart, or one going to the systemic circulation and one going to the lungs. That's not present. We just have one large trunk leaving the heart, okay? And that's due to failure of the aorticopulmonary septum to form, okay? Next is our detransposition of great arteries. So normally, physiologically, our great arteries rotate and they spiral. However, if we have failure of the aorticopulmonary septum to spiral, okay, that means that we're gonna have parallel pulmonary and systemic circuits, okay? So the aorta is gonna leave from the right ventricle anteriorly, whereas the pulmonary trunk is gonna leave from the left ventricle posteriorly. So what happens is we have two closed off systems that run in parallel to one another, okay? And this is due to the fact that we have linear development of the aorticopulmonary septum. This is highly associated with maternal diabetes. So if you have gestational diabetes, this can be associated with transposition of the great vessels or the great arteries. And on imaging, we're gonna see egg on a string appearance on chest x-ray, okay? Next is tricuspid atresia, which isn't as high yield, but it's just the absence of a tricuspid valve. Fourth is gonna be our tetralogy of Fallot. And this is the highest yield thing out of this whole entire section. So the tetralogy of Fallot is gonna be due to, okay, displacement of the infundibulum towards the right ventricle. And this leads to four symptoms. One, pulmonary infundibular stenosis, right ventricular hypertrophy, overriding aorta, and a VSD. So once again, if we have a displacement of the infundibulum, that tells you that there's a tetralogy of Fallot, and you're gonna see the four signs of tetralogy of Fallot. One is pulmonary infundibular stenosis, meaning that we can't get blood as easily into the pulmonary arteries as we normally can. So going from the right ventricle into the pulmonary arteries, we have a stenosis there, okay? So the pulmonary infundibular stenosis. And that stenosis, depending on the severity, gives us the severity of the case. So if you have a very severely stenosed pulmonary infundibulum, then you're gonna have a very severe case of tetralogy of Fallot. Number two, we have right ventricular hypertrophy. So because we can't get into the pulmonary artery, our right ventricle is gonna hypertrophy. It's gonna try as hard as it can to push blood into that pulmonary artery. And so that's gonna cause hypertrophy of the right ventricle. And that's gonna lead to a boot-shaped image on chest x-ray. So boot-shaped heart on chest x-ray. Next, we're gonna have overriding aorta, which causes a rightward deviation of that aortic valve. And then lastly, we're gonna see a VSD, okay? So, patients are always gonna present this way. They're born, okay, and they're very young still, however, they're gonna have these TET spells. And TET spells are just cyanosis, okay? These are just cyanotic babies during times of crying or feeding, okay? Because When we have crying or feeding, we're going to be increasing that pressure in the systemic circulation, in that vascular or the pulmonary circulation, and we're going to cause increased cyanosis. Okay, so how can we treat these babies? These babies are going to be seeing squatting, okay, or knees to chest. So these babies start to squat because that increases systemic vascular resistance. And if we increase systemic vascular resistance, that pushes more blood through that pulmonic artery. Okay, so it's going to go through that stenosed pulmonic artery. Okay, because we're increasing systemic vascular resistance, so it's going to be kind of pushing it back. Okay, so you can squat, which increases that systemic vascular resistance, or you could bring the knees to the chest. Okay, so what's one way, the main way that we can treat this is by maintaining our PDA. If we keep the patent ductus arteriosus available, then that means that we're going to have blood from the aorta coming back into the pulmonic arteries and getting oxygenated. Okay, so once again, since we have at birth higher pressures now in the left side compared to the right side, that ductus arteriosus is no longer going from the pulmonary artery to the aorta. It switches once we're born. And so the aorta is going to be pushing blood because it's higher pressure compared to the pulmonic artery. So it's going to push blood from the aorta to the pulmonic artery in order to get it oxygenated. And we bypass that stenosis of the pulmonary artery. Okay? And what's one way we can maintain the PDA? We said it prior, but it's going to be that prostaglandin E. So PGE1 or PGE2 is going to keep that PDA open. Okay? This has some association with 22q11 syndromes like DeGeorge. However, that's lower yield. Okay? Next is total anomalous pulmonary venous return. So this is when all of our pulmonic veins drain back into the right heart, and we just have a constant loop, not as high yield. Lastly is Epstein's anomaly. If you see a mother who's taking lithium during pregnancy, the number one thing they're going to ask you about is Epstein's anomaly. Okay? And all this is that we're going to have the displacement of the tricuspid valve. Okay? And that leads to atrialization of the ventricle. And they love that word, atrialization. Okay? So essentially, we're making that ventricle smaller. So we have a large right atrium, but a very small right ventricle because we've atrialized it. And it's highly associated with lithium exposure. So those are all of our early cyanosis, right to left shunts, okay, and congenital heart diseases. Now, for our left to right shunt congenital heart diseases, we have our very easy ones. We have the VSD, ventricular septal defects, our atrial septal defects, ASDs, or our patent ductus arteriosus. Okay? These are going to be left to right, so once again, we're not going to see cyanosis early on, we're going to see it later on. And we'll talk about why we see it later on. But first, VSDs. The ventral septal defect, okay, one of the main causes of ventral septal defect is membranous. So when we form the ventricle septums, the membranous portion does not form, and that leads to a ventricle septal defect, okay? So it's mainly that membranous portion. Now, what we need to know and what they love to ask is, and I've already touched on it, harsh holosystolic murmur is going to be seen, okay? And they love to ask about O2 saturation. So since we have blood coming from the left ventricle and pushing it into the right ventricle because it's a left to right shunt, and we have higher pressures on the left side, so high pressure to low pressure. So oxygenated blood comes from that left ventricle and it pushes into the right ventricle. We're going to see increased O2 saturation in the right ventricle and the pulmonary artery because we go from the right ventricle into the pulmonary artery. We're not going to see increased O2 saturation in the right atrium because this occurs after the atrium. However, with an atrial septal defect, we'll see O2 saturation increase in the right atrium, the right ventricle, and the pulmonary artery, okay? And the reason behind that is because we're getting oxygenated blood now from the left atrium into the right atrium, and then that right atrium sends its blood to the right ventricle, which sends its blood into the pulmonic circulation, the pulmonic artery, okay? The ASD, we already touched on this, but it has that wide fixed split of the S2, okay? That's very important. And our VSDs and ASDs, along with majority of all of our AV septal defects or endocardial cushion defects are going to be associated with Down syndrome. Chromosome 21, okay? Now, lastly is our PDA, okay? The PDA is going to have a continuous machine-like murmur as we touched upon, okay? And we can close it by giving the patient NSAIDs, endomethacin, or we can keep it open, right? And that's favorable for tetralogy of Fallot by giving the patient PGE1 or PGE2 agonists, prostaglandin E1 and E2 agonists, which are one of the main medications is known as alprostadil. Okay. Now, this is highly associated with congenital rubella syndrome. Okay. Now the question is, how do we get cyanosis? If we're just having oxygenated blood going from the left side to the right side and getting reoxygenated again by the lungs, how do we get cyanosis? Well, over time, as we continuously have more blood go into the right side of the heart and through the right side and through the pulmonic arteries are going to increase in response to stress because now there's increased blood flow into the pulmonic arteries. And so we're going to have pathologic remodeling of the vasculature. So the whole entire pulmonic artery system is going to change, and that's going to lead to pulmonic atrial hypertension. So pulmonary atrial hypertension. And so that causes increased levels of pressure on the right side of the heart. And at times, that pressure gets so large, we push it over to the left side. So now we've increased our pressure so much that our pressures on the right side of the heart is so much higher than the pressures of the left side of the heart that we actually are going to push deoxygenated blood into the left side of the heart, and it's going to go into circulation, causing cyanosis. So that main thing is that we're going to see pulmonic arterial hypertension due to pathologic remodeling of vasculature. And that's due to the fact that there's so much blood going, over 10 years, right? These patients are going to present at 10 years old. 10 years, you're going to have constant blood, increased blood flowing through the pulmonic arteries. So that's going to lead to a pathologic change in remodeling of the vasculature. Lastly is the coarctation of the aorta, okay? And so for the coarctation of the aorta, all we have to know is that it's just a kink in the descending aorta, okay? And so it stops blood from getting to our lower extremities. Now at times in embryological development, if our ductus arteriosus, okay, is going to be below the coarctation, in utero, our body will not sense hypoxia to our lower extremities because we're still supplying oxygen to the rest of our body because our ductus arteriosus is below the coarct, okay? Whereas preductal coarctation, okay, is going to be narrowing or postductal coarctation is going to be narrowing after the ductus arteriosus, okay? And so if we have narrowing, the coarct, after the ductus arteriosus, in utero, we're going to be able to sense the hypoxia. There's not enough oxygen getting to our lower extremities. So because we're in utero, there's so many stem cells floating around, we're able to form collateral vessels. And we're able to get around that coarct and perfuse the lower extremities. So this is a little better because we're able to form collateral vessels. However, you're going to hear a murmur in the back of the scapula if we have the collateral vessels. So that's for postductal coarctation. Okay, we form collateral vessels, okay, and we'll hear a murmur on the back of the scapula once that baby is born. This is highly associated, once again, with Turner syndrome, okay? The preductal coarctation is worse because we have narrowing before the ductus arteriosus, so we do not have formation of collateral vessels, okay? And so we're going to see cyanosis of those legs compared to the upper extremities. These patients are at a very increased risk of cerebral hemorrhage, known as Berry aneurysms, okay? And the reason behind that is because we have a coarct, a kink in the aorta, so majority of the pressure is going to be pushing up towards the brain, which leads to increased blood pressure of the brain, leading to an increased risk of cerebral hemorrhage or rupture of the Berry aneurysms.